Pedro, can you just kind of summarize some of the other really fascinating studies and trials that are ongoing right now in MCSPC that you're part of or anybody else is part of?
Yeah, no, absolutely. Actually, it's great because it's getting so much crowd. This space is getting so much crowded, and we know it's going to be even crowded. So one of the studies that I can quote, or two or three, one is exploring darolutamide, which is another novel AR-directed therapy on top of ADT and chemo that became a standard of care. So that's one. It's called Arison's study. The other study is asking a little bit different question, which is called PEACE-1, basically adding abiraterone to docetaxel. So basically plus minus radiation to the primary tumor. So I kind of addressed the point, the role of addressing the primary tumor in the context of metastatic disease. We have others. We are exploring triplet therapy, for instance, with chemotherapy, carboplatin, cabazitaxel on top of abiraterone, called Cascara, which is an academic led trial. We are seeing PSMA therapeutics, which we're going to talk a bit later today, moving into the hormone-sensitive space with a large phase 3 trial is already approved via the cooperative groups in NCI, and that's going to launch, relatively soon. So it's exciting times, and we're going to have more good problems in the near future.
Yeah. And some molecular profiling too. We're doing a couple of studies with PTEN loss, looking at PIK3, AKT, druggable targets. Anything exciting for you all in the MCSPC, William?
Well, I think, just like in the MCRPC setting, in this metastatic hormone-sensitive setting, the question is sequencing and combinations. And we're going to get some prospective data, but just as a reminder, when Enzyme was presented at ASCO, one of the reasons it became a plenary talk, I believe, was that there was about 40% or so of the patients actually got chemo and were randomized to enzalutamide. And there was a chance to look at the 40% who got chemo versus the 60% who didn't. And basically, in that group that got chemo, there didn't seem to be an additive benefit to using enzalutamide. That's not proof, but it seemed to suggest that combining these treatments, at least in this early look, is not necessarily beneficial. So we really shouldn't be doing that outside of a clinical trial. Some of the trials that Pedro just mentioned will get us to that point about whether we should be giving chemo plus an AR-targeted therapy to these patients with hormone-sensitive prostate cancer.
Yeah, it's a great point. So yeah, it's always been the sort of the bane of the development of the taxanes, right? They've really had a hard time finding couplet benefit, but hopefully we'll see that at some point.
I was just going to make one other comment, about the Enzyme trial. So what the Enzyme trial at the moment shows us you don't want to put them together, but like the Arches trial, where patients were allowed to have had up to 6 cycles of docetaxel before they got the Enzyme, before they got the enzalutamide. That trial actually showed a benefit whether you had gotten previous docetaxel or not. Those patients actually were having an improved outcome. And so one of the things that we forget about when we're thinking about sequencing is there is data that supports that, let's say you chose to give a patient docetaxel for 6 cycles, and then there's data that actually would support maybe adding a drug like enzalutamide after that might be beneficial to them as well. So
I think the subset
not at the same time.
I think that the subset of patients in that trial, and if we think about Titan 2, it was only 10% of patients or so who had the combination of all three. So I absolutely agree that this information will be coming, but at this point at least, I don't use all three, certainly not concurrently because of the enzyme toxicity data, but the added benefit in the setting of financial toxicity and potentially side effects, we just don't know. But it's something that with PEACE-1 we'll see, and with other studies, I definitely look forward to seeing soon.
Yeah, that's a great point. You're right. There was a small, in both in Titan and in Arches, where we saw some benefit, and it wasn't predefined, and you looked at the forest plots. But it's an interesting point. Patients may sometimes want to say, hey, you gave me my 6 cycles of docetaxel. My PSA is still nattering. What else can I take?
That's exactly, as you said, a patient I just saw who had gotten 6 cycles of docetaxel, and his PSA had dropped, but now was plateauing. And he said, and he still had lots and lots of bone metastases, and he said, anything else you should add?